We're just about there. Wonderful. We are live. Good afternoon, everyone, and welcome to our virtual symposium entitled Breaking Down Lupus Medications. My name is Kelly Rosetta, and I am the creator and executive director of the Portland-based nonprofit More Than Lupus. Today's educational event featuring lupus patient and pharmacist Van Vu, will be an important one. So it is documented that 50% of lupus patients do not take their medications as prescribed. Now, patient noncompliance can lead to less symptom management, disease flares, and many other unfavorable outcomes. Now, it's easy for someone who doesn't have lupus to say, come on, just take your medication, just do it. But for the patient, starting a new medication can be scary and very nerve-wracking. We struggle as patients, we struggle with our desire to live a better quality of life, but we fear the unknown of the RX. Many of us only have minutes in our doctor's visits, virtual or otherwise, to discuss multiple issues. And often the medications are on the last of the list as we are heading out the door and your doctor is beginning to think about the next patient. So you don't know what questions to ask. You don't know if it's okay to ask them. You're scared about the side effects. You're worried about the possible interactions. And that leads to fear and worry and worry and fear. And it stops you from taking medication. Today, we hope to understand more so that we may fear less. I'm quoting Marie Curie, who was a scientist and a chemist, just like a pharmacist. And she said, nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. So quick disclaimer, this symposium is designed to inform. However, it does not replace the advice of a doctor or a medical professional. If you have concerns regarding your current medication, please reach out to your care team and seek their medical advice before changing or stopping your current treatment protocol. So without further delay, it is my pleasure to introduce today's speaker, Van Vu. At 26, Van holds a Doctor of Pharmacy degree from OSU, as well as a Master of Business Administration degree. She is also managing an illness that we are all too familiar with, lupus. Please welcome Dr. Van.
Thank you so much. It's my honor to be here today, and I'm really excited to be able to share with you some of these lupus medications, answering your questions as a pharmacist and a patient. So please send them my way. All right, should we start the presentation? Okay. All right, Kelly, can you see the screen okay?
Yes, I do. Thank you.
All right, so my name is Van Vu. I graduated from Oregon Health and Science University and Oregon State University. I'm class of 2020, so by no means am I an expert, but I can provide my perspective as both a patient and pharmacist here today. I wanted, in collaboration with Kelly, be able to share the ins and outs of these medications, most common medications amongst lupus patients, to maybe debreak some of the myths, as well as bring light to the facts and share with you my personal experience with these medications. I think is what everyone's interested in, especially, you know, if you've taken them yourself, you have a different perspective because you know what it's like. So before going straight into these medications, I just wanted to give a brief overview of what the pathophysiology of lupus entails. And I know that most of us already have a great understanding of this disease, living with it day in and day out. But this is just to help you be able to understand why we are taking a certain medication for lupus, how it helps treat lupus. And so this is just a brief introduction. It has a lot more details, but I wanted to just keep it simple enough so that we can understand the medications. So the first step typically in lupus patients involves a kind of environmental trigger in conjunction with our genetic predisposition of responding to programmed cell death. So in our body, we have a process in our cells where it will trigger cell suicide in light of, for example, there's damage to your cells. So that's just your natural way of getting rid of these damaged cells in your body. And so in a normal human being, oftentimes these are just easily cleaned up by the immune system. In patients who have lupus, this process gets a little bit tricky in that your immune system now recognizes these damaged cell components as something that's foreign to your body. And that's where we have this cascade or triggered immune response that amplifies throughout your body. And that's where you see this inflammation that's local, and then that becomes chronic because as you know, this is a normal process of your body, so it never stops. That's why inflammation in lupus patients are often a chronic thing. And then this ongoing inflammation may at the end cause permanent damage to specific parts of your body. And I'll go into more details on the next slide to help you understand maybe in a more realistic way of patients with lupus. So in reiterating step one, you have this environmental trigger, for example, the sun. Lupus patients are always told to stay out of the sun, put on sunscreen, but why is that? You know, why do we have to be more careful or cautious? It's because when you're out in the sun, when your skin gets tanned, or in a worse scenario, burnt, you have damaged skin cells. And that triggers your body to have this programmed cell death, or, you know, killing off those damaged cells, skin cells, in order to regenerate new ones. And that triggers the immune response in lupus patients especially. That's when you may see a flare. And so this immune response recognizes these damaged cells as antigens, or what we call foreign substances to our body, to be attacked by the immune system. So, and those are called antibodies. So that's in a simpler term, when you have lupus, you're basically allergic to yourself. So your body starts attacking itself. And that the final step, which is permanent damage, when this the immune response travels throughout your body to your kidneys, to your heart, to your lungs, that's when it can become permanent damage to these organs because you have your immune system attacking these organs. So that's just my understanding of lupus. I'm hoping that I can help someone understand a little bit better, but I'm not a medical doctor. So if you have any questions, further details, this would be a great conversation to have with your doctor. As pharmacists, we always would like to have a treatment goals. In patients with lupus, we know there's not yet a cure, and so we focus on what we can for treatment. And the first goal is to manage acute periods of life-threatening disease activity. For example, kidney failure. And the second one is you want to minimize the risk of flares and periods of stability. So for example, putting on sunscreen, staying out of the sun, minimizing stress, which is easily said but not done. And then managing the symptoms that are not life-threatening but affects your quality of life. So hair loss, pain associated with lupus, and that's the basic three goals we tend to strive for, especially in lupus. In general, for lupus medications, there's 4 classes of medications that are most commonly used. The first one is anti-malarial, which everyone probably thinks of as Plaquenil or Hydroxychloroquine, which has made its headlines recently with COVID. And then the second class of medications are immunosuppressants, which I will discuss further in details later on in the presentation. That's to help with the immune response that is associated with lupus. And then we also have anti-inflammatories and pain relievers. These are more for symptomatic control. And there are different kinds of pain medications as well as anti-inflammatory medications. So we'll go over those. And then lastly, now with the more newer development for drugs used in the treatment of lupus, we have biologics and Dmards, which are disease-modifying anti-rheumatic drugs. So the first thing that I wanted to go over are FDA approved medications, something that Kelly and I both wanted to highlight. These are medications that most of us lupus patients either are currently on or have experienced. And unfortunately for us right now, there are not that many to be specific. And so we'll go over them and feel free to send in any questions. So the first one is aspirin, and treatment of lupus depends on the part of the body being affected by the disease and the severity, of course, of the problem. The FDA first approved its drug of aspirin in 1948, and then later approved corticosteroids steroids such as prednisone, which suppress the immune system and reduce inflammation. And we will go into greater details about corticosteroids in the next slide because there's so many. But to discuss aspirin, how it works, it inhibits the inflammatory pathway, which is what is most helpful for us lupus patients. Aspirin at a low dose has an antiplatelet effect. So you will see this in heart disease as well, not just in lupus patients. It has an antipyretic effect, so it helps with fever and an analgesic effect, so with pain. And then at a more medium dose, that's when we see the anti-inflammatory effect come into play. at a higher dose. It may also be used to treat rheumatic fever. The dosing varies. You have baby aspirin at 81 milligram, and then the regular dose at 325 milligram, which is probably more often seen in lupus patients, used 46 times daily. And then for side effects, because it has that antiplatelet effect, you see an increased risk of bleeding. And when used in conjunction with anticoagulants or antiplatelets, this risk is additive. And then other than that, because aspirin is a salicylate derivative, there is a chance of an allergic reaction or hypersensitivity. Ringing in the ears or tinnitus is often seen in higher doses. And I remember from my lecture that back in the day, people used to give children aspirin to the point where if they start having like a ringing in the ears, that they know that that's an adequate dose. Luckily, that's not used anymore to kind of gauge the dosing, but that was a thing. And then corticor steroids decreases inflammation by suppressing the immune system as well as reducing its activity. We'll go into more details on the next slide for side effects, but usually steroids are always tapered on and off, and that is to when you are taking, especially at a high dose of steroids, your body stops making cortisol. And so when you just abruptly stop your steroids and your body isn't making any, your body can go into shock, and that's not a great thing because you'll experience a lot of side effects and it can be dangerous even. So that's why it's always tapered on and off. The next drug that is maybe some considered, my rheumatologist calls it kind of like a vitamin for all lupus patients because everyone gets it. It's hydroxychloroquine or Plaquenil, and that's been recently studied in COVID and has met its headlines as well. And for a period of time, I know that a lot of us patients struggled to get Plaquenil at the pharmacy because it started to be on shortage. So it is an antimalarial drug that's used for the prevention and treatment of malaria. In lupus, it impairs the interaction between the antigens and antibodies. So if you remember in the previous slide where your immune system kind of marks these cell fragments that are considered antigens or foreign substances in your body for the immune response to basically start reacting to them. That interaction is impaired when you take Plaquenil. And so it helps kind of slow down the immune system in having that reaction. It's not immunosuppressive. I will say that a lot of the misconception is that Plaquenil is immunosuppressive. It is not. It's immunomodulatory. And so it modulates your immune system. It does not suppress it. It's taken once to twice daily. And side effects wise, you may experience an upset stomach when you first start it. The one concern with side effects that most providers will be paying attention to is vision changes or irreversible toxicity in your eye, in your retina to be specific. And that is something that is closely monitored. That's why you have to have an eye exam before starting Plaquenil long term. Studies, and do not quote me on this, but from my doctor, within the first 5 years, you very rarely see this. It's past the 5-year mark that you may see the side effect of vision changes. However, it's not something that everybody experiences, or it is a listed side effect, but that does not mean that you will get that side effect. So just want to make that clear. So now you can, for the first 5 years of treatment, you don't even have to have an annual eye exam. That's just a guideline thing. That's not to say that everyone's different, and some population may be prone to eye toxicity than others. So it's important to follow your doctor's advice on what to do in order to closely monitor that, so that you're stopping the drug before anything permanent happens. For drug interactions, I listed QT prolonging agents, and I understand not everyone knows what this actually means. So I'm just gonna briefly explain it. So, the rhythm of your heart, and you have an EKG, so you have that interval of the QT interval. And so certain medications can prolong that interval, especially in patients who already have any conditions related to that. Adding on medications that might prolong that interval have that additive effect. So you're more likely to experience the side effect if you have multiple drugs that act on this. So for example, escitalopram or Lexapro, citalopram or Celexa, certain antibiotics like ciprofloxacin, levofloxacin. And that's just something to monitor. It's not a absolutely contraindication. It's just something that to keep an eye on when you are on concurrently on multiple medications that can prolong that QT interval. And then the last medication before that, I just wanted to talk about, I got carried away talking about all the adverse effects, but what's beneficial about Plaquenil is there are few side effects in comparison to the other drugs that we see with lupus being used to treat lupus. So it's on the milder side, even though I probably made it sound like there's a lot more going on. And it has been seen to prevent joint pain, as well as the skin rash and mouth sores in lupus. And so, there's no really drug that shown to prevent these. It's more for to manage the symptoms. So this is pretty cool. And it has a long half-life of 40 days. So what does that mean? Well, it takes 40 days to half the concentration of Plaquenil in your body. And so it sticks around for a while, which means when we're on a drug shortage for Plaquenil, it sticks around. So, but that's not an excuse not to take your medication. And then on the flip side, though, it takes several weeks to take the full effect. So it's not one of the more quicker agents used for flares. And then most recently, FDA approved Benlysta or belimumab. And this is the first targeted therapy for lupus. This was approved in 2011. It's directly delivered into the vein, and it's designed to target a B lymphocyte stimulator, which reduces the impact of abnormal cells thought to be a factor in the development of lupus. So it inhibits the survival of B cells, in short. And why do you want to inhibit B cells in lupus? Well, B cells secretes your antibodies that are targeting your own cells. And so this reduces that potential of antibodies, so autoantibodies, which we hear are a marker for lupus. And then it also plays a crucial role in the antigen presentation. And so that interaction between the antigen and the antibodies, that's where Benlysta will play in that role. For dosing, we have the weekly injection as well as the monthly infusion. And I know that Kelly has discussed her preference. So There's that. Of course, the monthly infusions at much greater dose than the weekly injection. So the side effects are more, I would say, you would see it more amplified during the infusion than the injection. However, it might be more convenient for others if someone's a month thing and you're done, you get it over with, versus something that you have to self-inject weekly. Some patients don't prefer to self-inject, and that's okay. Other things with Benlysta is that it's an injectable, and so that in itself will have a better availability than something that's taken orally, because when you take a medication orally, it goes through what we call, I'm just blanking, but basically your body isn't absorbing as much of it because it goes through metabolism before it reaches your bloodstream. And so something, when you inject something, that availability is a lot greater. I do want to mention that the side effects for, the drug interactions for the Benlysta have not been studied in clinical trials. We don't want to give biologic Dmards. And yesterday, we had this discussion, Kelly and I. So it's okay to give with something like Methotrexate. You would never see Benlysta given in conjunction with something like Rituximab, because that just basically wipes out your immune system. You're just too high risk of an infection at that point. And so you typically don't see that in practice. And then cyclophosphamide is another interaction. It can amplify the adverse effect of cyclophosphamide, and that's why it's not recommended to use together. So that's that. All right, so corticosteroids steroids are many, and these are just some that I've listed. These are FDA approved for lupus. And their potency differs. Most commonly we see prednisone, and that's, I think, I actually haven't, now that I'm just talking about it, I think, okay, why prednisone? But I'm sure there are reasons as to why for the treatment of lupus. And so short-term side effects for lupus patients who have lived with lupus, you either have been on a steroid for a short term or currently are taking it long term. And short term, the side effects may include things like an upset stomach, you retain a lot of fluid, you may notice changes to your appetite and mood, and have difficulty sleeping at night. For women, specifically, you can notice more hair growth on your face, as well as you can have irregular or absent menstrual periods. And this did personally happen to me, and so I think it's more common than we realize. So why do we even use steroids in lupus? So it works by decreasing the inflammation and suppressing the immune system. What's great about it, especially short term, is that it works very quickly to alleviate lupus flares. And especially when there is organ involvement during the flare-up. So that's one way to just quickly control your flare. And then long-term, there are many side effects. We think head to toe. You can have psychiatric changes, you can have high blood pressure, thyroid disease, glaucoma from increased blood pressure. The list goes on and on and on. So why do we even use it then if it's so difficult in the side effects profile? Well, if you think about it, the benefit of preventing permanent organ damage in this case outweighs these side effects, the risk of these side effects. And most often they are reversible once you stop the steroids. And so for someone who's at the verge of losing your kidney versus taking something chronically, experiencing, stretch marks or acne or having a moon phase and a buffalo hump, which is a fat deposit in your upper back. Yes, it's not great. And I've had all of that. But at the end of the day, would I rather do that than lose my kidneys? I think I'll, take the first option and stick with the steroid for long term. So that's why it's not pleasant, but it helps keeping everything calm for lupus. All right, do you have any questions, Kelly?
Yes, there have been some questions that have come in. One of them was pre-submitted. So I'll read this one first because it's on the lines of what we're talking about, which is corticosteroids. So this person said, I have a love-hate relationship with prednisone. I don't like some of the side effects, but I love that it works so fast. How does prednisone work so fast, but my other lupus medications like HCQ, Methotrexate, can take months before they start helping?
That's a great question. And to be honest with you, I think I would have to go back to like the mechanism of action in order to answer that question. I think on top of my head right now, I don't have anything that I feel confident enough to deliver that answer to you, and I'd be happy to get back to you. But I think with prednisone and steroids, it's just down to the way that drug works in your body in general, how it alters that inflammatory pathway in your body. That's quicker than something that takes time to develop those changes. So like Plaquenil taking weeks because it has to alter that all those interactions in your antigens and your antibodies. And so I think I would have to look more into that to provide you with like a detailed answer.
Thank you. I appreciate that response. Someone from our live feed asked, who's just recently started taking methotrexate subcutaneous injections, will methotrexate side effects lessen over time?
So everyone is different. And in general, with all medications, your body does get used to that medication. So yes, your side effects may lessen over time. But is it to a degree that you will notice? And is it to a degree that will make you tolerate that medication long term? That's not guaranteed.
Here's an interesting question that was pre-submitted. I use CBD at night to help me sleep. Are there any lupus medications that interact with cannabis?
Oh, I think that would be more of a specific question for your doctor and pharmacist. I would have to have your medications list, and then I'll be able to run that for cannabis. On top of my head, I can't think of any interactions right now that stands out for me between like all the medications that we're going over today. having an interaction with cannabis, but that's something that I definitely would have to check. We don't necessarily see cannabis being entered in, especially in the community setting, as one of the medications that currently on. And I know that that's one of the things that being used increasingly for pain management or sleep. But yeah, I would have to look that up. I don't think I'd be able to answer. I mean, depends on what medications you're taking, right?
Yes. Thank you. I appreciate that. No, we're throwing a lot of questions at you here. One person from our live feed asked, how long should I be on Plaquenil? It's been 8 years.
So Plaquenil in the setting of lupus is a lifelong medication. And that's because of its preventative effect, not just to control symptoms. And so when there is the benefit of preventing flares or skin rashes or mouth sores, joint pain, et cetera, if you're tolerating it well and you're not having any eye toxicity, chances are your doctor will continue you on that medication until you show any type of irreversible side effects such as eye toxicity.
I think that's it on the questions for right now.
Okay. All right. Those are really great questions. But yeah, the prednisone, I will definitely get back to you on that. At some point, I may have learned it, but right now it's not coming. It's not coming back to me. The other things I do want to mention with steroids is that I listed minor for side effects, and that most of the time steroids given in conjunction with immunosuppressants will have that added effect of immunosuppression. And so steroids itself can be immunosuppressing at a certain dose for a certain duration. So when you take prednisone for a 5-day course, that's not going to be immunosuppressive. Prednisone in particular, taken at a dose of 20 milligram or greater for a duration of 14 days or greater, that's when it becomes immunosuppressive. And that's when you will see patients being given antibiotics to prevent infections. Sometimes that's Bactrim, given 3 times a week, but that's why. And then other than that, I think we'll move on to the off-label medications, and we'll go into all of the other classes of medications. So the first group or class of medications that I want to go over are immunosuppressants. I think a good majority of us lupus patients will be taking this. Either you've heard of it or you have firsthand experience. For me, I am on Mycophenolate, and so I've had my fair share of swallowing this pill, and I always complain to my rheumatologist about how it gets stuck in your throat. I don't know if there's anyone that can relate to that. Methotrexate is another agent often seen in lupus, as well as azathioprine. And then in more severe cases of lupus, like central nervous system lupus, you will see cyclophosphamide and cyclosporine. But I wanted to focus at least on the top 3. And we also see this in organ transplant. They're used to prevent organ rejection. And so in patients who have a kidney transplant, they will be, you'll see them be on azathioprine or mycophenolate to prevent their body from attacking that organ. In lupus, we're so lucky that our body thinks our own organs aren't our own. And so we have to take medications to prevent that immune response. So yeah, and then methotrexate is used for the treatment of rheumatoid arthritis. You may see it in psoriasis and as well as certain types of cancer. At specific doses, it is an anti-neoplastic or cancer agent. All right, so let's get into kind of the same setup for our FDA approved medications. We have mycophenolate, which is known as Cellcept or Myfortic, and I can explain a little bit in the difference between Cellcept versus Myfortic. So Myfortic is enteric coated, which means it has this coating around the tablet that prevents the disintegration of the tablet in your stomach. So that just releases, it slows the absorption of the medication. And so you may experience less stomach upset with Myfortic versus Cellcept. That's why when patients can't tolerate Cellcept, they're often tried with Myfortic, even though it's both mycophenolate. And the way that it works is that it inhibits the growth and division of immune cells, taken twice daily. And the most side effects or common side effects that patients will notice are it may make you feel nauseous. It may induce diarrhea in some patients. So I've worded as upset stomach because in general, you'll that can kind of put an umbrella term on that, but that are some of the things that patients tend to complain about, and that's what keeping them from taking the medications. For me personally, it's just the size of the pills being larger than Plaquenil per se, and so I also have trouble swallowing mycophenolate. And because it's an immunosuppressive agent, you'll see that your risk of infection will increase. And so that's always listed as a side effect in all immunosuppressants. Drug interaction wise, birth control is a big one, especially because it lowers the concentration of birth control in your bloodstream. And that's both estrogen and progesterone derived birth control. So what does that mean? Well, it means that your birth control may not work as it should. That's why it's always recommended to have 2 forms of birth control when you're on mycophenolate. It's also teratogenic, meaning that if you do get pregnant on mycophenolate, it can have, it really can impair your baby, essentially. And so there is a black box warning for that. So yes, I think especially if you're a woman in the reproductive age, your doctor will have gone over with you about this. Azathioprine inhibits the synthesis of the pathway of immune cell precursors. And so it acts a little bit differently, but it's still once daily. And so some patients may prefer that as opposed to mycophenolate that's usually given twice daily. Side effects are similar. Everyone's different. However, some may tolerate mycophenolate better. Some may tolerate azathioprine better. I will say that there was a study in 2011 by the New England Journal of Medicine comparing mycophenolate and azathioprine, and they did show that renal response and preventing relapse in patients with active lupus was better with mycophenolate. And so that's probably why you see mycophenolate more used in lupus nephritis. I can't say for other types of lupus how that plays out. Mycophenolate is taken on an empty stomach. It has great rapid absorption and really great bioavailability, which means just availability of the drug in your body. So it's a 95% with CellCept and 72% with Mycortic. It 72% might not sound that great, but some drugs are down to like 5 and 10%. So this is a great absorption as well as the level in your body you can achieve with this. Food, taken with food, why is it taken on an empty stomach? Taken with food, it decreases the maximum concentration that's in your body with mycophenolate. It doesn't interfere with absorption, but it does do that. And so that's why we recommend taking mycophenolate on an empty stomach. However, if you are experiencing an upset stomach and eating helps with that, we rather have you eat and take your medications than not eat and not take your medications, especially in transplant patients. This is one of the medications where you cannot go without in order to keep your organ transplant. And so that's what we would tell patients. If you become pregnant and you are on mycophenolate, or you plan to become pregnant, I don't think anyone would intentionally want you to become pregnant on mycophenolate, but if you plan to become pregnant, the usual switch is to azathioprine for your medications. And then the next agent is methotrexate, and this, the mechanism itself is unknown for how it would help lupus specifically. However, the way that it works is that it inhibits DNA synthesis, repair, and cellular replication. So you can imagine if it prevents the making of cells in some part, it can contribute to helping lupus in the way that we are generating, you know, with more cell replication, there's more the potential for a triggered immune response, right? It is dosed once weekly, and it's available both as an injectable and as an oral agent. We see this more when first-line agents like mycophenolate or azathioprine are not working for patients. That's when we bring on another agent like methotrexate to see if there's any response. And it may work out for certain patients, and that's great. The dosing will be adjusted as well, depending on the response. And I don't know if, I have not had personal experience with this. So side effect wise, this is just for, you know, what's listed. I don't have a personal experience with methotrexate. And so maybe, I don't know, Kelly, maybe you can speak to your experience.
Yeah, so I've done both oral methotrexate and sub-Q methotrexate, so injections weekly. I fortunately have not experienced from either many side effects, thankfully. I did feel like I kind of, the 24 hours after either injection and or pills, feel a little foggy and have mild stomach upset, but nothing major with myself, thankfully. And I find the subcutaneous, whatever small side effects I had, I feel like they're even less with the injections because they're not going through my GI tract. So I think I prefer the injections over the pills. And thankfully, the medication does not sting. They're very small needles. And if you were to compare it to the Benlysta subcutaneous injections, it is a breeze. It's so easy to do the methotrexate injections compared to the auto-injector Benlysta, which is refrigerated and which really stings and, you know, all of that. So to me, it's been a relatively convenient drug and a very effective drug, particularly for those of us who have lupus. So lupus and rheumatoid arthritis overlap. I think methotrexates are really, for me, I can speak from my personal experience, has been a really great drug for me.
That's, yeah, so there you heard it. For drug interactions, we tend to avoid NSAIDs or non-steroidal anti-inflammatory drugs, as well as aspirin with methotrexate. And the reason being is that it can increase that concentration of methotrexate in your body. And so you just have to be closely monitored. And typically, if we can use other agents, we would do that first if you're on methotrexate. And then if there are no better options, then yes, you can still use NSAID and aspirin. However, we try to avoid it whenever we can. And same thing with alcohol. It's just not recommended with methotrexate. And then cyclosporine and cyclophosphamide, I just wanted to give you the overview there. Cyclosporine is known to have a lot of different drug interactions, and that is because it acts on one of the enzymes in your liver to metabolize a great majority of most medications. So we're talking about 75% to maybe 85% of drugs, and it's called CYP3A4, and it induces that enzyme. And so what happens is that your medications will be metabolized a lot quicker in your body, meaning it won't stick around for very long. And so it decreases that effect in your body. And so when you take cyclosporine, it most likely will decrease the effect of other drugs. And so that's why, and too many to list, so I will just keep it at that. Cyclophosphamide prevents the cell division, as well as suppresses the immune system. This is given intravenously, and I know that sometimes patients with more severe cases of lupus may have to get the infusion. With all infusions, typically there are a chance for infusion site reactions as well as other side effects. It's used for cancer, and so the toxicity with cyclophosphamide is the most concerning in using for the treatment of lupus. It is at a lower dose than what we would use for cancer. However, that possibility of toxicity is still there. Are there any questions so far before I go on, or?
Yes, so what is the alcohol and methotrexate relation there?
Yeah, let me pull that up really quickly here. So we see with, and I will pull up my notes here for you. One moment. I think for methotrexate, with alcohol, you just have that added liver toxicity effect because methotrexate is metabolized by your liver. And so when you drink alcohol, you are just adding more for your liver to work on. And so, yeah, so here from my notes, it's just having that, what they call hepatotoxic effects or liver toxicity with alcohol. Is it okay to have a drink or two? Yes. But know that you are putting your liver to work a little harder.
Thank you for that. And then Chelsea asked, is sulfasalazine, is that how you say it, safe for lupus patients?
It is used for other indications. Using for lupus, I don't see that being used much for lupus, but so it is used in rheumatoid arthritis as well as ulcerative colitis. And so safety-wise, it's a safe drug to put it in simple terms. Safe in lupus, I think I have to have an elaborating or, what she means by that. Because neither mycophenolate or azathioprine or methotrexate are FDA approved for lupus, yet we still use it quite often. So sulfasalazine, we don't see it as often, but if it works for someone with lupus, then I think it's definitely an alternative to explore.
Is that a sulfa-based drug?
Yes.
Because I'm wondering if that's where her question's coming from, because some rheumatologists believe that lupus patients should stay away from sulfa medications, particularly sulfa antibiotics, and how that can somehow trigger a lupus flare. So I'm curious if maybe that's, I don't want to assume, Chelsea, but per your question, I'm wondering if that was kind of where you were going with that.
Yeah, let me look it up really quick and see if there's any warnings for that. I have not heard about lupus avoiding sulfa drugs in particular. That may be something that I have to look further in. I know that, for example, antibiotic Bactrim, which is sulfamethoxazole trimethoprim, it is used when you are on high doses of steroids all the time to prevent infections. It is used to treat other types of infections, and to avoid sulfa drugs and how that contributes to lupus is something that I think I would have to look up and research on. I have not heard that personally. I don't know what your experience has been with that, Kelly. I don't know if you've heard anything.
I think it started with Dr. Thomas, who wrote the Lupus Encyclopedia, and there were some studies done at the NIH regarding sulfa antibiotics triggering lupus disease activity and increasing disease symptom indexes. And so my rheumatologist says try all the other antibiotics before you go on a sulfa-based one, just to be on the safe side. And I've heard from other rheumatologists as well who are starting to concur that that is a safer route based on some studies out of NIH.
Yeah, I you're teaching me something new. So like I said, you know, even though I have lupus, I think that there are a lot of things that I still don't know, and maybe have not experienced. So that's why you don't become well versed in it per se. And so I would be more than happy to get back to you on that question. Yeah, let's do that.
Yeah, I think for the sake of time, maybe we should keep going, and then any questions that aren't answered, we'll try and go back and get some information for them after we're done with the presentation.
All right. And then as far as pain medications goes, there are so many. I just wanted to go over a few classes of medications that are commonly seen in lupus patients. And I'm sorry, there are background noises. If you would like me to move upstairs, I can do that. But I think we're coming to an end when my family members are coming home. But yes, ibuprofen and naproxen are what you can see are available over the counter. Ibuprofen at a higher doses can help with reducing that inflammation in lupus patients. And naproxen versus ibuprofen. Naproxen is longer acting, and so that's why it's taken twice daily versus ibuprofen, which is taken every 4 to 6 hours. Longer acting medications come with greater risk of side effects because it sticks in your body for a longer period of time, and so that's something to consider. More convenient dosing, of course, and other than that, the other NSAIDs, which are non-steroidal anti-inflammatory drugs, are more selective in the COX-2 enzyme, and so it reduces that potential for gastrointestinal side effects. With NSAIDs, there's always that risk of gastrointestinal bleeding, and so with more selective COX-2 enzymes, which are celecoxib, diclofenac, or meloxicam, those we see less side effects. However, that's just specifically for gastrointestinal. There is an increased effect for cardiovascular. And so just, you know, plus and minuses. I'm sorry, I'm going to close the door. With those. And then for opioid options and non-opioid options, I've listed them there as well. Gabapentin and pregabalin or Lyrica, they interfere with the pain signals, especially the nerve transmission. And so it's often used for nerve pain. And you see this with diabetes as well. And then muscle relaxants like tizanidine or cyclobenzaprine are acting on your motor neurons to relax those muscles. And so that can sometimes help with the pain that we lupus patients experience. Tramadol is probably used more often than oxycodone, hydrocodone, and that's just abuse potential associated with opioid options or opioids in general. And then fentanyl, I don't think you would often see in lupus patients, is more for cancer, as well as chronically not well, or not pain that's not well managed. And there's different formulations. Fentanyl is available as a patch versus oxycodone. Hydrocodone are available oral agents, and so is tramadol. And then we just want to briefly mention antidepressants that also have pain potential. That includes duloxetine, nortriptyline, and mitriptyline. Nowadays, we do prefer duloxetine over something like nortriptyline or amitriptyline. These are tricyclic antidepressants, and the simple reason for that is they carry more side effects. So duloxetine is a serotonin norepinephrine reuptake inhibitor. It is commonly first agent for depression. And so if it has pain potential, especially in patients who also battle depression and have pain, this is the preferred agent. And with that, I will go to the last the last category that we have, which is biological Dmards or disease modifying antirheumatic drug. Rituximab is FDA approved for certain cancers and rheumatoid arthritis. And the way that it works is that it activates B cell cytotoxicity, mediating the killing of B cells, which we previously mentioned that it's contributing to that immune response in lupus. And so what it can do, it helps reduce the signs and symptoms of inflammation, as well as the progression of damage that is seen from chronic inflammation. All right. And because I'm starting my career as a pharmacist, we always talk to patients about medication adherence. And so what does it mean to be non-adherent? Why are pharmacists always asking you if you're taking your medications? So patients always tell me, when I ask, are you taking your medication? Yes, I'm always taking your medications. In reality, we all know that nobody takes their medications. There's no such thing as 100% adherence rate. There's a difference between forgetting to take your medications, a few times a month versus intentionally not taking your medications at all. And so what pharmacists want to do is that we want to help our patients be able to remember how you can take your medications. And what we typically counsel on is, are you organizing your medications? If you're taking multiple, having a pill organizer is very helpful because it kind of divides it into a week or, like time of day, so morning, afternoon, and then evening. There are a lot of great ones on Amazon. And so that's just one of the things that you can try because they come in, like bottles. And so it's hard to keep track. A reminder technique is to set an alarm on your phone to when you want to take or need to take your medications. Some patients find it helpful to put your medications in the living room table so that when you're watching TV, you're reminded to take your medications. You can take your medications with a certain task of the day, like eating breakfast, lunch, or dinner. That sometimes help patients. So it's setting things that are consistent. I would talk with your pharmacist, set your medications on automatic refills. That way, when you get the call from the pharmacy that your medication's been filled and you haven't ran out of medications, you kind of know to yourself that, oh, maybe I haven't been taking all of my medications. This is one of the ways that pharmacists also know when patients aren't so-called adherent or taking their medications, as you'll see, they fill their medications like 3 weeks late or 4 weeks late. We kind of know, like, all right, what's going on here? That's how we track it. And then when we go to counsel you, feel free to ask us questions. We're not just here to instruct you on how to take your medications. Feel free to ask about side effects. Feel free to ask about how your medications work in your body. And like questions like today would be great. If I was in the pharmacy, I would take the time to look it up for you if I don't know, and chances are that I won't know everything because it's impossible to, have everything memorized, but we have the resources to do it for you. So don't feel like you're taking so much of our time, even though the pharmacy is busy. At the end of the day, patient care is why we're here for. And so every patient deserves that time, especially when you do pick up your medications. And then feel free to call us afterwards with questions. Just because you left a pharmacy doesn't mean that we're no longer available to you. You can give us a call and ask, and we'd be happy to answer those. Then I wanted to leave you with some reliable drug resources that you can, in your own time, look up how your medications, work, certain things, et cetera, et cetera. Daily Med is by the National Institute of Health, and that has the most up-to-date FDA package insert of your drugs. You can read through that. It is catered to healthcare professionals. So a lot of times might be difficult to understand. Medline Plus is more patient-friendly. And so that's something that you can use. If you are a healthcare professional, there are specific drug resources like Lexicomp, Dynamed, or clinical pharmacology catered specific to medications that you can use. And I'm sure if you're in the field, you are familiar. And with that, I want to thank everyone for listening to me today. Hopefully it's been helpful. And thank you, Kelly, for allowing me to have this opportunity to share my thought and put together this little presentation for everyone to maybe help in some way feel a little less scared about their medications. Personally, I will share that no, I don't take my medications all the time like I'm supposed to, even though I'm a pharmacist, and I go to work and tell my patients, hey, you need to take your medications. On many levels, it feels very hypocritical, but we're all humans. And like I mentioned, mycophenolate has been a personal struggle for me to swallow even every day, and I have to take it twice a day. So I get it. It's hard. It's not easy battling lupus every day, but know that there are others that can help you get through this. And there are help out there if you need it. Pharmacists in particular are more than happy to help you. I've had patients that have lupus come, and I'm more than happy to pull you aside into the consultation room to talk about your medications. So thank you.
Well, thank you so much for spending the time with us today to help us break down the most commonly used lupus medications. I love the fact that pharmacists are invested in our health. So in honor of National Pharmacist Month, I just want to say thank you. We appreciate you and the thousands of pharmacists around the US that work in our benefit, that are invested in helping us, and that are there and available to answer questions. It never occurred to me that my pharmacist was spying on my non-compliance. But now it makes perfect sense because I get the texts and I'll get the phone calls if I'm not picking up a medication on time. So all this to say, you have a team of people that want to see you live the best life you can with this illness. So let them help you. They are there. Whether your pharmacist is at your local drugstore or your pharmacist is in a clinic or hospital setting, they are there to help. So thank you once again, Dr. Van, and we're so happy to have you as part of the More Than Lupus community. And thank you also for sharing your lupus story and telling us more about how these medications impact you personally. This will be available to share on Facebook Live. Also, there will be a link to YouTube, and you can watch on YouTube later for your convenience if you didn't get to see this in its entirety. Thanks again, guys, and stay tuned for more exciting things and informative things coming from More Than Lupus. Take care. Bye-bye.